Good evening, my dear friends and colleagues. And today, a new episode in Ramadan Retina recipe from the Egyptian Vitreoretinal Society. And today we have a very special guest, a guest which I call an international star. She's not only a star in her country, but also on every meeting and every Congress. She's there. And she has great talks and presentations, very educative. And she always shows us challenging cases, especially in the field of pediatric retina. And therefore, we decided to host her in this event in a very difficult topic, which is the PHPV, or persistent fetal vasculature. I would like to welcome Professor Sengul Ozdek, professor at Gazi University, Ankara, Turkey. Dr. Sengul, welcome.
Thank you, Hany. Thank you. It's my pleasure and honor to be here with you again. I'd like to thank you a lot because you have prepared everything for me, and I'm really very happy to be here again to share my my life and also my cases with you.
Thank you, Sengul. And we consider you part of the Egyptian Vitreoretinal Society as well, and a regular guest. So, to start our episode, we would like to know, Sengul Ozdek, the human being, or your life. Can you please tell us how your education in school, your life, and we would like to know you closely.
Okay, thank you. Okay, I will try if I can. And if you allow me to share my pictures
go ahead.
with you. Yeah, so I just put my headshots starting from the primary school till, these days. In the bottom line, you can see my primary school ages in the left and bottom. That was at the beginning of my primary school, and then secondary school, high school, and this is the end of my high school ages. And then started my university years. You see these ones, and this is from graduation, and then I started my ophthalmology career, and these are from more recent, but still like 20 years before, I should say.
Still having the same looks.
Really?
Yes.
So this is from the beginning of my secondary school with my father. And then I decided to become a doctor, and I entered the Hacettepe University Medical Faculty, which was the top one in our country. And
it's in Ankara, I guess.
It's Ankara, yeah, in Ankara. And it was, I started in 1987 and then completed at 1994. And
were your parents doctors, physicians?
No, they are not. They are not actually. My father was in construction business, and I met my future husband there during my school years, starting from phase 1, I should say. Dr. Ali Ozdek. He became an ENT surgeon then. And this was during our internship period, and this was from our medical faculty graduation ball.
Very nice.
And thank you. And then I started my residency in Gazi University for ophthalmology. I decided to become ophthalmologist when I did my ophthalmology clinic during phase 5, and then in those years, and still I guess Gazi University was one of the best in ophthalmology, so I decided to do that after passing an examination. And during those years, I
Very nice.
married with Dr. Ali Ozdek during our residency years. And then I became a faculty member also in Gazi University School of Medicine with this big, very nice family, my mentors and all the friends.
Was it common at that time that females get into retina as a subspecialty?
Actually, not vitreoretinal surgery, but medical retina a lot. But in vitreoretinal surgery, much less, I should say. Mm-hmm. Usually, female doctors were in medical part.
Yes.
But I choose ophthalmology because there was a surgical part as much as also the polyclinic parts. So
yes.
I liked surgery, as you know.
Yeah, so, definitely. Can see that.
My mentor was Dr. Berati Hasan Reisoğlu, and he was, a great person for me, and he always supported me in many aspects. And then Egemen came. Egemen is my son in 2000. And then we went to Bascom Palmer Eye Institute in 2004 to work with Dr. Harry Flynn. Mm-hmm. He is a great mentor, another great mentor. He has a very great personality, I should say. It was really nice to be.
How long did you stay in Bascom Palmer?
Just 3 months. Just 3 months.
But it was quite useful for you.
Right, because yes. I was already doing the vitreoretinal surgery with my mentor in Gazi University, with Dr. Hasan Reisoğlu. I just wanted to, expand my imagination and to see the system and all those things. And I met Dr. Berokal there. She was pregnant then, and Dr. Murray. And also John Kitchens was fellow like me in those days.
Okay.
Now he is very, well-known vitreoretinal specialist. Then Elif came. After I became an associate professor, Elif came to our life, my daughter. And then I was not happy with my pediatric retina surgical results. So I decided to do something for that. And I know that Michael Tracy, Dr. Capone are the best in this field. And then I contacted with them and I went to Beaumont Hospital and just to observe their surgeries. And that was really very, very informative for me. And then I learned the philosophy of pediatric retina, I should say, there. And then my family, my passion is my family, as all of us, expanded. And this is me. So this is from the start, from the beginning of primary school and high school, and at the end of my residency. And this is almost today's pictures. So you can see
I can notice the evolution of haircuts. I mean,
right.
Very nice, really nice.
Right, thank you. So
thank you.
It reflects those era, I guess.
Yes, definitely. So your hobbies, Sengul?
Yeah, thank you. I have some hobbies. One of them is singing, actually. We have a chorus in Gazi University, medical faculty, and also in Turkish Ophthalmological Society, we have another chorus. And I'm not a soloist, but I do it as a chorist. So it's at the behind. You sing and you don't have to study and work too much, and you enjoy a lot. So I love it. I should say that.
Very nice hobby indeed.
And we do this, in between the sessions, and whenever you find the time. Of course, they are giving we have a chorus chef. And he sends us all the songs, and we work beforehand. Then when we come together, every time we have time, we go there and we start, practice. And it's really time taking, but it's marvelous. I should say that I enjoy a lot.
Definitely changes the mood.
Right, totally.
Yes.
And I do some sports also.
Skiing?
We do skiing, yeah, with family every year. But this year we couldn't because of COVID. We just escaped only for this year. Sometimes with the friends, sometimes with family. And also we do play tennis. Actually, it's been a long time I couldn't play, but I know that you're a good player. I hope we can do it.
We're going to have a match one day.
Yeah, I hope so. And also I do Pilates for like 20 years or so. I like it. It's another, mood changing thing, I should say that. But my biggest passion is teaching and learning. I love it. When I see people around me who want to learn, I always, try to, teach. I really like it. If I wasn't a doctor, I would be a teacher. I should say that.
Yes.
I love it.
Or on a TV show, as we have.
I don't know.
Yes.
But yeah, to teach
a nice photo.
Somebody gives me a lot of pleasure, I should say that. And I really thank to you because I met you first in Cairo Retina meeting in 2015. That was a great meeting, I should say. That was my first time in Cairo, and we went to pyramids and
it was the Egyptian Vitreoretinal Society meeting at that time.
Oh,
yes.
right.
GVRS.
Egyptian.
Yes.
You're right. Sorry for that.
Yes.
And you were here with us. You remember Cesare was with us also.
Oh, yes.
So we missed him so much.
We missed him. He was a great guy. Yes.
Yeah, I hope he rests in peace.
Now, after knowing Dr. Sengul Ozdek closely and personally now, please stay tuned after this short break because we have a very interesting scientific episode about persistent fetal vasculature. Stay tuned and we'll be back soon. Welcome back again. And now the main part of this episode about persistent fetal vasculature. And Professor Sengul Ozdek will share her recipe for dealing with these difficult cases, which many surgeons refrain from doing and try to refer it to someone else. Dr. Sengul, please go ahead and share your screen.
Thank you, Hany. Again, it's my pleasure to be here with you to share my knowledge with you. So today I will talk about the surgical management of persistent fetal vasculature syndrome. You know that we have different types of PFV syndrome, like anterior, posterior, mixed, and combined with some other pathologies. But they are all in a different spectrum. For example, for anterior PFV, we can have very severe ones with microphthalmia, with total vasculature of the lens and or even the vitreous. And we can have very mild forms with a very small attachment to the back of the lens, a very thin vascular hyaloid artery, which doesn't cause too much disturbance to the eye. In the posterior PFV also, we can have very small tractional retinal detachment at the back of the eye without causing any problem in the front of the eye, or it may cause a closed funnel retinal detachment, which may be almost incurable. So it's a spectrum of diseases. And we have some diagnostic tips like, as you see, radial hairpin loops, in the iris, radial iris vessels, very typical. Unilateral microphthalmos, prominent ciliary processes are very typical, and pars plana is not developed or underdeveloped. There is no zonules, and there are also some peripheral retinal abnormalities. I want to emphasize this during my talk. There's an anterior PFV, and you will see the video that I couldn't eat the lens material with the vitrector because it was like a cartilage. I tried it after cutting it because when I create some edges, I could do that, but I couldn't eat it, so I had to take it out like a foreign body. That's an interesting one. Another one, this is posterior, and this is very interesting because as you see here, this was like a normal cataract, and there was no fibrovascular tissue, but when I do the ultrasonography, there was a probably fibrovascular stalk there. So I thought that this is PFV. Then I started the surgery. So when I started it, I didn't do any posterior capsulotomy, but even from the beginning, the lens material was moving at the back of towards the vitreous cavity. It was moving, and I then realized that hyperechogenic part was not a stalk, because there was not a stalk as you see here. Those were the lens material which filled the Cloquet's canal. And it was during the developmental stage, of course. So this was the first case that I have seen like this. And I had another case. This was a bilateral case. I had one more some years afterwards, and we have written that also. So this is interesting. So the posterior capsule may be already absent from the beginning. So you should be prepared for vitrectomy for these cases. Another very bad complication of this, another bad surprise. You see, when it is a total fibrovascular tissue behind, even if you cut it, then I just wanted to cauterize the stalk, but then I realized that something was hanging from the front. That was the retina. Yeah, it was the retina continues with the fibrovascular tissue. When you cut the fibrovascular tissue, you ended up with retinotomy, a large retinotomy. And it was a giant tear, so you had to do the posterior highlight removal and all the rhegmatogenous retinal detachment surgical approaches, steps, and put the silicone oil. This patient did well, but not all of them do well. I will show some others.
So giant break is a common complication in these cases.
Right, especially for the severe anterior PFV cases. Yes. We have seen this peripheral retinal elongation in 80% of our anterior PFV cases, and it was very correlated with the extent of the lens opacity. If it is just comprising the 50% of less than 50% of the lens, it's okay. But if it is more than that, it's more with peripheral retinal elongations.
Yes.
And as you see here, they are usually continuous with these fibrovascular tissues. You see, this is a pigmented plaque, as I told you before, in the front part, and the peripheral retina is continuous in that path. You see, it's continuous in the pars plicata area, pars plana area. So when you see such things in the front, please just follow the pars plana, pars plicata area if there's a retinal elongation, and avoid entry from those sites. Otherwise, you can end up during the sclerotomy site with retinal breaks. So, what to do to avoid retinal damage? Probably you will ask that.
Yes, that's my question.
Because I tried to avoid that, because the case which ended up with giant retinal break was like 10 years before, maybe more than that. And then this was another very old case, and this was a severe PFV case, and I just take the central part, I left the peripheral part, and then followed the case. And then what happened within 5 years, the peripheral retina started after 2 years or so to contract. I mean, actually, the fibrovascular tissue contracted, and that pulled the peripheral retina slowly and slowly within years, and it ended up with this. So you can't avoid retinal detachment, either tractional or rhegmatogenous retinal detachment. So you have to, deal with this fibrovascular tissue. You have to peel all those fibrovascular tissue. Otherwise, it will cause future problems.
Yes. Before we start this case, how do you deal with the posterior capsular remnants in these cases? In my experience, I have seen cases in which these remnants contract post-operatively, causing capsular phimosis, and they pull on the peripheral retina, causing a delayed giant break. I don't know. Can you tell us your experience and how you deal with it?
Actually, I totally agree with you. When you leave them, it contracts. It may cause pupillar obstruction. It can happen like within 2 weeks or so post-operatively, because most of these cases are known as standard congenital cataracts, and some pediatric ophthalmologists or cataract surgeons do it from the front, just like standard cataract surgeries. And then they end up with pupillary obstruction because of this contraction. And it may cause later tractional, but if you do the surgery from pars plicata, if you do the sclerotomy, you have already done a retinal break. But if you do it from the limbal approach, you don't have any retinal break, but just tractional, I guess.
Yes.
So.
Yes.
So this was another very interesting case. 2 months old, full-term baby with microphthalmia, very severe microphthalmia. You see there was posterior synechia, and the ciliary processes were elongated, and very bad fibrovascular tissue. I started, the vitrector didn't eat, and I had to cut it. And to start with the vitrector, I just do the lensectomy. Actually, it's not a lens, fibrotic tissue from the center, and I left the peripheral part just to see the periphery of the retina. And then I was trying to see if it is continuous with the retina. Then I noticed something. Retina was already detached from the periphery, as you see from inferiorly here. It was 360 continuous with the fibrovascular tissue. Even though you didn't cut it, it comes, it contracts and comes. And I had to take the retina, retract the retina with the iris retractors to continue with the surgery. So to continue with the posterior hyaloid removal, you have to do this. Otherwise, it will just, it will be a disaster. Mm-hmm. Although I could do the posterior hyaloid detachment and all, you see, I'm just evacuating the subretinal fluid there. It was very difficult surgery, I should say that. Very difficult, because it's a microphthalmic eye, retina was detached, and you have to do the posterior hyaloid removal in a baby, and after the removal, I did the removal of the remnants of the fibrovascular tissue and peripheral retinotomy and all those things. Although retina was attached, as you see here, but I couldn't avoid from hypotony, and I lost this eye because of hypotony.
So you would leave PFO as a tamponade in these cases, in some of these cases?
No, I didn't actually. Retina stayed attached with the silicone oil,
okay.
But the hypotony was the real problem.
Yes.
Yes, you're right. We can't, do the positioning in children, but since this was a small baby, it's easy to do the face down positioning and all those things, not a problem. So this is a posterior PFV case, 16-month-old, a mild one. You see, it is attached from a small point in the front part at the back of the lens, so you can do the lens sparing surgery easily. But before entering from the scleral side, you have to check if there is any peripheral retinal extension to select your place for sclerotomy. It's very important because if there is a retinal elongation area, you will have a retinal break. So I just cut the stalk and then check. Sometimes retina is within that stalk, so you can't go to the top, but to the root. But you just do it as small as possible without risking retina, and you leave the back of the lens, the part at the back of the lens just itself. It retracts, no problem. And this is when she was 6 years old with the effective amblyopia treatment. It was 0.2, not bad. You see, retina was attached.
Great result, and a very important tip, not to trim this stalk to the end because it contains retinal tissue, as you said.
Right. Mm-hmm. And this is a combined PFV case. You see, there is both anterior and posterior involvement. I always use end illumination to see if there is any retina at the back of that fibrovascular tissue or not. It gives clue, you know. And I try to relieve that retinal detachment, retinal fold from the periphery. And sometimes you can't because retina itself attaches to the periphery. But in this case, we could achieve that. When you relieve, you see those attachments, when you relieve all the retina, this is the fibrovascular tissue. It's like fairy chimneys. You know, in Cappadocia area, we have fairy chimneys with a rock at the top. So this was the rock at the top, as you see here. And then just leave it there, because you can't, it's very difficult to peel all the fibrovascular tissue. Just leave it there. You have a attached peripheral retina. These are spare eyes. You don't expect too much things from this if it's a unilateral case also. And when you leave it during the growth of the eye and the children, retina eye grows, but that fibrovascular tissue doesn't let the eye to grow, and it pulls the posterior, the retina towards the anterior, and the ciliary body towards the posterior, and it may end up with phthisis bulbi. So even if you prevent this complication, it's enough, almost enough.
It's very important that the stalk is constant, has a constant length, and the eye elongates. So the retina detaches with time. So they may present with a detachment after 2 or 3 years if they are neglected.
Right.
Sengul, you showed us really nice cases, and this was a heavy and delicious meal for Ramadan. So finally, I would like you to share with us your recipe for these cases of persistent fetal vasculature, these tough cases. Can you show us your recipe?
So this is my recipe for PFV cases. The first thing, you should be aware of peripheral retinal extension, especially in anterior PFV cases. You should check for that. Secondly, again, for anterior PFV cases, prefer limbal entry to avoid from retinal damage. Third, please check the entry sites in posterior PFV cases if you want to preserve the lens sparing vitrectomy. Check the entry sites if there is no retina or not in the sclerotomy sites. And do not leave peripheral fibrovascular tissue. It causes significant problems later. Be ready for rheumatogenic retinal detachment for these cases. And so it should be done by vitreoretinal surgeons, I guess. And you should check the for secondary glaucoma also, which is very common for these eyes in every visit. Thank you again.
Thank you. Thank you, Sengul, for sharing this very important recipe. And I guess many of our cooks are going to use it in their future surgeries. Finally, before we conclude, I would like you to give a very brief piece of advice to young retina specialists how to follow the path of Sengul Ozdek.
Oh, thank you. Oh, thank you for nice introduction and nice end. I think the most important thing is to want. If you want something really by your heart, the whole universe will help to you. When you want it, you just explore what to do and then do all the things required step by step. And if you work hard, as everything, without working hard cannot be done anything. And you use your heart also and your imagination. Imagination is the most important thing, I guess. If you want to do something different, you should first imagine. And you should just imagine if there's any other way to be done in a better way, you should explore for that. So you should trust yourself and work hard and imagine and do whatever you want. And of course, you should be polite to your senior people and to ask for help. Everybody wants to help, actually. We all want to help to our junior people. And I'm sure they will succeed if they really want.
Yes. Well, Sengul, I really enjoyed this episode. It's a very special one. And thank you very much for being our guest at the Egyptian Vitreoretinal Society. And my dear colleagues, tomorrow we're going to have a new episode with a new guest. And goodbye. See you tomorrow again. Thank you. Bye-bye.
I'd like to say one more thing. I would like to say happy Ramadan to all my friends. I also do fast during Ramadan, and I know how it is to fast. So happy Ramadan Mubarak.
Happy Ramadan to you. Ramadan Kareem, as we say.
Yeah,
Thank you,
Ramadan Kareem.
Thank you. Bye-bye. Bye.